During this brief video, we will focus on the presentation of various forms of trauma to the anterior segment, including chemical injury, hyphema, and open globe. By the end of this, we hope you are able to identify key features of chemical injury, hyphema, and open globe injuries, and determine when to make emergent ophthalmology consultations and how to best care for patients in the interim. Now we will utilize a few cases to illustrate examples of trauma to the anterior segment. We'll start with an 8-year-old boy who splashed liquid into his eye while playing in the garage. Per history from Dad, the fluid was strained to clogger. The event occurred about 1 hour ago, and the father immediately began flushing the eye with tap water and continued while on the way to the hospital. The patient reports pain, and he has no history of ocular conditions. A physical exam was deferred until sufficient irrigation was complete, with normalization of the pH of the eye to 7.0 to about 7.2. Once the exam was conducted, the cornea was noted to be clouded with focal limbic ischemia, and this is noted by the absence of visible blood vessels around the limbus. Visual acuity was 20/60 on the right and 20/20 on the left. Pupils were reactive and without RIPD. A little information about chemical injury to the eye. This can occur in the form of alkali or acid burns. Alkali burns are actually much more severe than acid burns, though both can denature corneal proteins and threaten vision. Alkali burns can be caused by ammonia or lye-containing products, such as certain household cleaners, including the drain declogger as mentioned in this case. Penetration of the toxin can occur long after the initial exposure, which is why continued irrigation is so important. Acid burns may be caused by hydrochloric acid found in pool cleaning supplies, or sulfuric acid, which is present in car batteries. Long-term complications from these burns include loss of vision, dry eye, corneal melt, and glaucoma, among others. Now for next steps in the cases of suspected chemical injury. The most important thing is to sufficiently irrigate. This can be done with any available non-caustic fluids such as tap water or normal saline, and the irrigation should begin immediately at the time of injury and continue until the pH has normalized. After stabilization, recheck the pH with narrow range pH strips if those are available every 30 minutes or so, as a change in the ocular pH can signify a retained particle in the eye that is continuing to elute chemicals. Make sure to place an emergent referral to ophthalmology. Now we will move on to a second case. This patient describes rear-ending a car at a stop sign resulting in airbag deployment. She complains of subsequent vision loss in her right eye associated with pain and light sensitivity, and this occurred about 2 hours ago. She denies diplopia and has no history of ocular conditions. On exam, there is no eyelid laceration or paraocular ecchymoses. She has decreased visual acuity in the right at 20/200, and she's 20/25 on the left. Extraocular motions are intact, and on pen light exam, you notice a significant amount of blood in the anterior chamber. This patient has a hyphema, in which blood accumulates in the anterior chamber as a result of blunt trauma to the orbit. Hyphemas can be associated with red eye, pain, photophobia, and decreased visual acuity if the blood obscures the pupil. The patient may complain of nausea and vomiting, particularly if intraocular pressure is increased. Be careful, don't check the intraocular pressure unless you have excluded an open globe, as this could cause further damage to the eye. The most common complication that we want to prevent in hyphema is rebleeding, and the greatest risk of this is at 3 to 5 days post-injury. In terms of next steps of care, a hyphema warrants an urgent referral to ophthalmology with a same-day or next-day appointment at the latest. Make sure to place an eye shield, and don't place anything under the eye shield itself to prevent increasing pressure over the eye. Instruct the patient to avoid NSAIDs and recommend strict bed rest with elevation of the head of the bed to about 30 degrees. And you can prescribe antiemetics to reduce nausea and vomiting, which could increase pressure in the anterior chamber and worsen the hyphema. The next case is a 35-year-old gentleman who fell into some brambles while mountain biking. Aside from being a bit scratched up, he is complaining of sudden vision loss and eye pain in the left eye. This occurred about 3 hours ago and is associated with red eye. He denies diplopia, and he had LASIK eye surgery to correct myopia about a year ago. On exam, the patient has a peaked pupil, which immediately increases the suspicion for an open globe injury. This patient likely has an open globe with visualized beginning of extrusion of the iris as seen in the photo. An open globe is an ocular emergency as vision is threatened in the injured eye. It can be caused by either blunt or sharp trauma, though a sharp mechanism may be more common. And things that should increase your suspicion of an open globe injury include history of hammering metal on metal, or if they're found to also have a fractured orbit. Patients with this injury often complain of sudden marked vision loss, and keep on the lookout for a shallow anterior chamber on pen light exam, as well as a peaked pupil with extrusion of ocular contents. If you have a patient in which open globe is suspected, perform a very limited exam. Do not utilize any eye drops or place any pressure on the eye as you risk further extrusion. Place an eye shield, not an eye patch. An eye patch can increase pressure around the eye, and if you don't have an eye shield available, you can make use of a plastic or a styrofoam cup taped over the eye. Make sure you place an emergent referral to ophthalmology in order to increase the chance of preserving or restoring vision, and consider whether the patient needs tetanus prophylaxis. Begin to prepare the patient in case of surgery. Make them NPO, conduct a CT of the orbits if you have not already done so, and give antiemetics and oral pain medication. So just to highlight a few of the salient points, in the case of an open globe, look for that peaked pupil and shallow anterior chamber with a story that fits. Immediately place that eye shield and call ophthalmology. For a suspected hyphema, place an eye shield and recommend bed rest until seen by ophthalmology. And for chemical injury to the eye, the most important thing is irrigation. Place a referral to ophthalmology and keep checking that ocular pH. This summary slide highlights the important information that we discussed, and I hope this presentation helped you become a little more comfortable with addressing patients presenting with ocular trauma. Thank you.